Morning, ma'am. Ma'am, please join. Dr. Apurva Shah here. Dr. Apurva Shah here, madam.
Good morning, Apurva.
Okay, fine. Thank you.
Good morning, sir.
Good morning, Dr. Mudheshwara. Thanks
Yes,
for
sir. Good morning,
joining.
sir. So thank you, sir.
Sunday
Thank you.
morning, it's a little difficult, I know. But
Good
being
morning,
Sunday,
Apurva.
we almost. Good morning, Rathore Sahib.
Good morning, good morning.
Pankaj bhai, क्या है साहब?
Yes,
Good morning,
good
Dr.
morning.
Gore, ma'am.
Good morning, Gurwan bhai. Good morning, everybody. Yes.
Good morning, Pankaj bhai.
Good morning, Gore madam.
Good morning.
Gore madam, good morning. Very good morning.
Good morning. Good morning.
How are you, ma'am?
I'm fine.
સાહેબ ચાલુ કરશું સૃજલ જોઈન કરે છે, મેસેજ છે 2 મિનિટમાં જોઈન કરે છે.
Okay.
Please mute yourself, somebody. Good morning, everybody. Thank you for joining on a Sunday morning. Today we are here to discuss about varicose vein. It's a PG masterclass, the same way that we do in exams. The student will be presenting the case in 2 parts because being in a virtual platform. The first is the history part and the second is the examination and the investigation part. Anybody, the teachers or the expert can stop at any moment if they feel that there is something going very wrong, or we can later on take slide by slide, we can ask the questions. Today we are joined by Dr. Mutheshwara Sanjay, sir. He is a HOD at Tirupati Medical College. We have Dr. Gore madam, who is ex-HOD at Sion Hospital. At present, she is working at Mumbai. We have our own Dr. G.S. Rathod sir, who is at present HOD at M.K. Shah Medical College, Ahmedabad. And we have Pankaj Modi sir, who is working at present at the Epic Hospital. We'll be joined by Dr. Shrujal Shah. I think he'll be joining in a couple of minutes. He's a vascular surgeon as an expert for all the newer modalities and technologies that we use in varicose veins. Shall we start? Mohit?
Yes, sir. Good morning, sir.
Good morning. Start slide sharing.
Yes, sir.
Good morning, Srinivasan sir.
Srinivasan sir,
Welcome.
good morning, sir.
Good morning, sir.
Good morning, sir.
Srujal has joined, Apurva.
Shrujal bhai, good morning, sir. Shrujal bhai.
Sir, good morning. Sorry for the delay.
It's okay.
That's right.
Let us start.
So I just
Mohit,
started.
start it.
Yes, sir.
Good morning.
Good morning, everyone. I am presenting the case on varicose vein. 35-year male from Ahmedabad, security guard by profession, presented with chief complaint of pain in the right leg for 6 years and dilated vein in right leg for 6 years. Patient was relatively asymptomatic before 6 years. Then he developed dull aching pain in the right leg, which was more in evening, aggravated on prolonged standing and relieved by lying down. And it is increased in severity since last 6 months. It is associated with dilated veins on the inner aspect of right leg and has gradually progressed to inner aspect of right thigh for last 6 years. Veins become prominent towards the end of the day and gradually disappears on lying down. Patient went to a private hospital 1 year ago and was advised for compression stocking, for which he wore for 6 months with no relief of symptoms and lost compliance. Patient has no complaint of trauma, fever, limb swelling, prolonged immobilization, itching, skin discoloration, bleeding, or ulceration. In past history, patient has no operative history and no history of diabetes, hypertension, or tuberculosis. In personal history, the patient is taking mixed diet with adequate sleep, unaltered bowel and bladder habit, and no addiction. Patient with no significant family history. Summary of history: a 35-year-old male patient, security guard by profession, presented with a complaint of pain with dilated veins over the right lower limb for 6 years, aggravated by prolonged standing and relieved by lying down with no operative history. General examination.
Mohit, please wait.
Yes.
Wait, Mohit.
Yes,
Yes,
let
sir.
us go to the first slide. Yes. Next. Mohit, yours is a patient of 35-year male without diabetes and smoking history, right? He is working as security guard. So how will you correlate all these findings in history?
So, by history, I will assume the patient is having primary varicose.
What do you mean by primary varicosity?
It is a congenital saphenofemoral junction incompetency with paucity of valves aggravated by prolonged standing.
Are you sure it is congenital SFJ incompetence? Because patient is 35-year male.
Yes, sir. It can be.
How it can be?
So, so because the patient will have some predisposition for the development of the varicose vein, which can get aggravated after the occupation with
Yes. So
prolonged standing.
you should have said that it is predisposing factor or the risk factors in which congenitally or hereditary patient's venous valves are weaker, and that is why he has developed. How do we correlate history of diabetes and smoking with the varicose veins?
The smoking leads to the depletion of the elastin and collagen, so by which the vein wall can become weak and it can become distensible and with progressive incompetence of the wall, leading to the
Yes, and
development of varicose vein.
diabetes.
Certain, certain diabetics, it can increase the complications related to the varicose vein.
Yes. And what does the occupation has to do with the etiology? Security guard.
Yes, sir. Sir, the profession of a security guard leads to the prolonged standing, which will lead to increase in the hydrostatic pressure in the superficial venous system, leading to the distension of the veins and progressive incompetence of the wall, leading to the formation of varicose vein.
Can you give us the details of pain he is having?
Yes, sir. There's a patient is complaining of mild and continuous pain. Throughout the day, which get aggravated in the evening, and after taking rest or elevation of the limb, the patient having feel sensation of relief of the pain and heaviness.
What is venous claudication?
So venous claudication is the development of the pain after exercise, which gets relieved on rest and elevation of the limb.
Venous, I am asking, not arterial. The
Yes,
claudication pain which occurs after exercise is
arterial
ischemic,
claudication.
arterial insufficiency. Venous
Yes,
claudication is having something else as a background and disease?
So in venous claudication, the pain will get relieved after the elevation of the limb.
No, it is all right that it is relieved, but why does it develop venous claudication and how does it develop? What are the pathophysiological explanations for development of venous claudication?
So because of the stasis of the blood in the superficial veins, leading to accumulation of the inflammatory markers and producing pain. And the stretching of the veins will also lead to dull aching pain.
So you want to say that it is purely because of superficial varicose veins, or it has something to do with the deep venous disease or venous insufficiency, what we call it as chronic venous insufficiency?
Sir, it is associated with chronic venous insufficiency.
Yes, most of the time it is associated with the chronic venous disease, and probably it is deep venous disease because per se exclusive varicosities in superficial system may not give rise to venous claudication. What do you mean by night cramps?
Sir, in night cramps, the patient will have a cramp-like sensation in the calf muscles during nighttime, which can be suggestive of severity of varicose vein and also seen in deep vein thrombosis.
Apart from varicose veins, which are the other causes of night cramps?
Sir, restless leg syndrome.
What is that?
Sir, it is characterized by the patient having pain during the night times with occasional tremors seen in patient with iron deficiency anemia.
Iron deficiency anemia. Okay. So why do you
No,
take history of
hello.
trauma and
There are
fever?
many other reasons for night cramps.
Yes,
Can you
yes,
remember
madam.
any more?
No, ma'am.
Calcium deficiency can give night cramps. Vitamin E deficiency can give night cramps. Magnesium deficiency can give night cramps. So there are plenty of reasons. So if somebody comes to you just with night cramps, you have to rule out all these conditions before putting the blame on whatever varicosities he may have. And another point that I want to make is right at the beginning of your presentation. You mentioned that I'm going to present a case of varicose veins. That is like patients coming to your clinic and telling you I have varicose veins. Huh? That is not the diagnosis to be made by a surgeon. Okay. Varicose
Yes.
veins is just a symptom of chronic venous insufficiency. So if you are saying that I'm presenting a case of varicose veins, are you mentioning the patient's complaints or are you giving your diagnosis? If you wish to give your diagnosis right at the beginning and tell us that you are presenting a case, then you should say I'm presenting a case of chronic venous insufficiency.
Yes, ma'am.
Rujal, would you like to ask anything?
Oh, Dr.
You are
Mohit.
muted. Yes.
No, sir,
Yes, sir.
perfectly
Yes,
fine.
sir.
Dr.
Excellent
Mohit.
flow. So we'll continue with this.
Yes,
Yes,
sir.
Yeah,
Yes, sir.
Dr. Muthishwara, sir.
Dr. Mohit, because you know that this is the varicose veins, you asked only about the varicosities. Any patient who comes with this type of pain always should be able to ask about associated arterial disease symptoms. Like patient
Yes,
has
sir.
got any intermittent claudication pain, and the anyway, you asked about that what's called other histories of. So, what is the history of? You asked no complaint of trauma. How the trauma will produces the associated with this varicosities? History of trauma.
Yes, sir. Sir, due to trauma, if the patient is having a fracture, which will lead to prolonged immobilization or the application of plaster cast, it can predispose to venous thrombosis and can lead to secondary varicose vein. If there is a trauma with a fracture leading to the injury near the arteries and veins, it can lead to the formation of AV fistula, which can lead to varicose vein, and the uh, uh, trauma leading.
Usually, this type of AV fistulas, trauma into AV fistulas will have a short duration of the development of this varicosities.
Why fracture is
Whenever
necessary? Why you are insisting on fracture? Can't patient have a immobilization without fracture?
yes,
Yes, sir.
yes, even
So
soft tissue
fracture is not
injuries.
important. I
Yes,
think
sir.
patient should have a fracture for immobilization.
No, sir.
Okay. So
Okay, what is the
yes, sir. Sorry.
this thing? Would you ask anything related to the superficial thrombophlebitis history? History of migrating thrombophlebitis type of history?
Yes,
What is
sir.
the
I have.
significance of migrating thrombophlebitis history?
So, migratory thrombophlebitis can be a external feature of any underlying malignancy,
Like,
like so pancreatic malignancy,
in,
colonic malignancy.
okay, intra-abdominal
And
malignancies. Yes, yes.
yes,
What is the name of that sign?
so Trousseau's sign.
Trousers. Why it is known as a
Process.
trousers sign?
Sir, it was invented. It was discovered by the Sir Trousseau, who was having the pancreatic cancer, and he has identified the findings in his own word.
Any other reason where you will find superficial thrombophlebitis?
So, because of itching and trivial trauma leading to inflammation of the superficial veins.
Can Burgers disease have a superficial thrombophlebitis?
Yes, sir.
It's a pan
Yes, yes.
vasculitis, so it can be present like a rarely as a superficial thrombophlebitis. Sir,
Mohit,
Yes, sir.
let us talk something about limb swelling and prolonged immobilization, though we have discussed in last few minutes, but I
Yes.
think it is relevant. You said about fracture, immobilization, and edema and DVT. Everything you have mentioned in no complaint of trauma. So how this limb swelling you correlate with the varicose veins?
So, if the patient is having a previous history of limb swelling with an unrecognized disease of deep venous thrombosis, patient can have a limb swelling in the past, which have now presented us with a varicose vein. Patient can also have a localized limb swelling with redness in case of superficial thrombophlebitis.
No,
And
no,
limb swelling is a yes, sir.
superficial thrombophlebitis can sometimes give rise to very small size localized swelling, but in clinical practice what we call it as limb swelling is either in the dorsum of feet or lower one third of leg, no, that
Yes,
is
sir.
not typically occur purely because of varicosities in the vein. It may be having some uh, background DVT or deep venous chronic venous insufficiency, which can be because of either prolonged immobilization or fracture. You say, can
Ye-
fracture in the leg give rise to limb swelling?
Yes, sir.
Hmm. So this patient has no limb swelling history,
Yes, sir.
no history of even prolonged immobilization.
No, sir.
Okay, and why do you ask about fever?
So fever can be a presentation of a deep venous thrombosis, or it can be seen in superficial thrombophlebitis.
Okay.
I suppose you know that quite often lymphovenous edema may be there in a combination. So doesn't history of fever give you at least one suspicion that whether he had filarial infection and he is having lymphatic edema as well as venous edema?
Yes, ma'am.
So that is important.
Yes,
So
ma'am.
along with differentiating venous disease from the lymphatic, you should remember other differential diagnosis also. Okay, next slide.
Yes, sir.
One important point, Mohit.
Yes.
Yes,
As
sir.
Madam asked, you mentioned that this dilated veins get relieved by leg elevation and symptoms are immediately relieved by night. So this is an important point when you have to rule out lymphatic edema.
Yes,
Yes,
sir.
next slide.
Yes, sir. So in
Next slide.
Summary. So you said something about it being a primary varicose vein. Why do you say it should be congenital? Then only you call it primary varicose vein? What is
No, sir.
primary varicose vein?
Primary varicose vein are congenital insufficiency of
So you want
saphenofemoral.
to say it is a congenital insufficiency. Wrong.
No,
No,
it's
sir.
wrong.
It
Sorry,
is
sir.
not a congenital. It can be a predisposing factor. So if it is
Yes.
congenital, then so many of they should develop varicose vein. What is meaning of primary varicose vein?
So primary varicose vein in which it is a cause is not known and it is characterized by incompetence of saphenofemoral junction and
Not
paucity of
saphenopopliteal. Again, last time you only mentioned saphenofemoral. So saphenopopliteal doesn't come in picture.
so it can also be with
So
yes,
what
sir.
about other perforators? Why only saphenofemoral? So don't specify saphenofemoral only because your patient has a saphenofemoral doesn't mean that primary is saphenofemoral. Do you
Yes, sir.
understand? Do not
Yes.
generalize. So, right. So what were you saying now? Continue.
Yes. So incompetence of the valves and paucity of valves get aggravated by prolonged standing.
So only standing will cause it.
No, sir.
You can
With patients with using excessive muscular contractions of the lower limb can also lead to development of varicose vein.
Srujal, you were going to say something, please.
So by primary, you mean there is no definitive cause leading to varicose vein, like
Yeah.
DVT or trauma, any other cause leading to varicose vein. There are multiple reasons. So you should not speak congenital. It's a very wrong term. You should not. You should
Yes.
avoid that term. There are
Yes, sir.
symptoms like KT syndrome and Parkes-Weber syndrome and all. That is different thing. But this is and very young age, 7 to 8 years kids, you can see varicose vein, but still you may not be able to label it as congenital.
Yes, sir.
So that's what I was saying. Do not stamp it as a congenital. Primary and congenital are not synonym. Primary when the cause is not known or you are unable to appreciate the cause. That is the primary. It can affect predominantly saphenofemoral but can affect saphenopopliteal or isolated valve. What is a real congenital varicose vein?
So I don't know, sir.
AV malformation usually, that is the one. And there are some syndrome I have forgotten. If the Srujal can remember, that's fine. Where there can be presence of varicose vein.
The
Triple
clipper
tenor.
drainage.
Triple tunnel, yes.
Parkes-Weber, you have deep veins, anomaly and superficial veins are dilated along with the lateral patch and all that telangiectasia and pigmentation. Those are congenital problems, and otherwise, rest all are we can say as a as per the evaluation it will come up.
Yeah. So yes, most of the varicose vein develops because of the prolonged standing. You can associate it with prolonged standing. You said what can be the other reason, which was very common before 10, 15, 20 years in India. Now it is
Sir,
definitely decreasing. Yes?
Sir, in athletes and rickshaw pullers,
Rickshaw pullers, particularly hand rickshaw pullers, they were very, what must be the reason there? Actually, they are exercising.
so because of excessive muscular contractions of the calf muscles, they are using the calf muscles where during which the the contraction of the muscle will cause emptying of the deep veins. But due to excessive contraction, there will be also predisposition for the development of reflux into the superficial venous system, causing the formation of
Strong,
varicose vein.
persistent contraction cause the repose. Sir, madam, sorry, please.
No, go ahead. I mean, I was wondering why calf muscle contraction should cause varicosities. If at all, it will give to emptying of veins, isn't it?
Yes,
But
ma'am.
what happens in rickshaw pullers? Or
Ma'am,
what
because
happens in people who do exercises with tremendous weights?
Yes. Now we should get the hint.
Yeah, I have tried to do that.
because of the sustained pressure in the deep venous system, it can lead to the damage to the venous valve and thinning.
Why varicosities occur in pregnant women? One
Ma'am,
more
because
hint.
of the compression of the deep venous system leading to increase in hydrostatic pressure.
Is it not increase in intra-abdominal pressure?
Mohit, still you are
Yes, ma'am.
limiting yourself to the leg veins only. Go to the abdomen.
Yes, sir.
Yes. So madam has already given you the hint. Rickshaw pullers, they are not only pulling the rickshaw, they are also doing lot of weight and carrying lot of weight, and doing so their intra-abdominal pressure rises tremendously high, giving rise to very high pressure in the leg veins. So in spite of calf muscle contraction, which is known as peripheral heart,
Yes.
the venous return fails and there is venous hypertension in the leg, which can lead to reflux or leak of blood through the perforators.
Yes, sir.
Along with this, I will just add, along with this, it will give rise to damage to the valve of the vein.
Yes.
That will give rise to development of varicose.
Yes, sir.
Mohit, madam said something, and you also are. What is venous hypertension?
Uh, So venous hypertension is the development of the raised pressure in the ankle veins.
What is a normal venous pressure at ankle?
So, so 5 to 10 mm.
I don't know. I'm asking. Sorry. Sujal,
So 5.
I have forgotten, to be frank.
This is typical exam.
It is, I think, 10 to 15.
And I am now
right.
no more professor. So I don't need to read it. I think so.
Yeah.
Sir, it will depend on height of the patient.
Yes,
To some
exactly.
extent.
Yes, madam. Yes, madam.
And
That is
when
the
you
point.
define venous hypertension, it is
Column of blood.
venous pressure more than 30 millimeters of mercury is called as venous hypertension.
So when you talk of venous hypertension, you should know normal value and abnormal value.
The best answer can be, RA level, what is the pressure, intra-abdominal deep venous pressure, and then peripheral pressure.
Yes.
So if you say this answer, you will get good score.
Let us go to the examination.
Yeah.
Okay, fine. Describe now.
In general examination, I have examined the patient with informed consent with adequate exposure under daylight in different position as and when required. Patient is conscious, cooperative, and oriented to time, place, and person. Fairly built and nourished. Temperature is normal. Pulse is 90 per minute in right radial artery. And blood pressure 120 by 80 millimeter of mercury in right brachial artery. No lymphadenopathy, pedal edema, pallor, cyanosis, clubbing, or icterus.
Excuse me, what is adequate exposure?
Adequate exposure in this case is from lower abdomen till the foot.
Okay, accepted.
Umbilicus downwards.
Yes. Inspection, the patient's left lower limb appears normal, and on right side, multiple dilated tortuous veins present over the medial aspect of the entire right leg and lower thigh. No swelling,
Can
scar,
you show us
redness.
the picture along with, so that we can
Yes.
also see? You are describing right lower limb?
Yes, sir.
So
Okay.
left lower limb is normal.
No, it
Yes,
is
sir.
not normal, but
Is it
he is
normal? Left
describing.
lower limb is normal.
No, it is also showing some visible veins and varicosities.
Which we can't see obviously, probably.
No, we can see. You can zoom, sir, madam, and you can see.
Okay, fine. So the point is, if many patients will have a bilateral varicose vein, how will you describe them? Very simple question of undergraduate.
I will start with the patient complaint of.
What your answer should be, as the patient will have a bilateral disease, I will describe more symptomatic side first.
Yes.
How will it help? Many ways. You will be describing the more disease portion, and usually examiner will skip the opposite limb. Same thing goes for hernia and that. That is very basic tip. Always, so patient has a bilateral disease. As the patient is more symptomatic on the right side, I will describe right side first. Right? And if the left side is normal, as you have said, that fine. Left side is normal, and then I am describing right side. Okay.
Yes. There is no evidence of swelling, scar.
Hello. Wait.
Yes,
Madam.
yes.
you look at that middle picture that you have projected.
Yes.
Yes.
Can
Yes.
you notice the difference in the calf circumference in these two?
Yes, that's what I was going to say.
Right and left, yes. There is
Hmm.
The
definitely some.
right calf is much bigger than the left one. You should take measurement then.
Have
Because
you taken
edema may
measurement?
not be, you
Also,
may not always see it as pitting edema, but you take calf circumference, the volume is increased, which itself indicates that there is more content in that calf.
That's very
Yes.
well
And
observed.
anything else that you
Yes.
can notice in his feet? Now let me be specific.
There is some edema, madam. I can see the edema.
No, he mentioned there is no edema. That's
Hmm.
why I'm pointing out that the calf is more voluminous.
More edematous, yes.
What about his feet?
It is
dilated veins are also present, and there is a more
Feet.
hyperpigmentation in the right side as compared to left.
No, I'm talking about his feet particularly.
Can you observe the flatness in the feet?
Can you see collapsed
Yes.
arch in both his feet?
It is
Yes.
totally
Does it
flat.
have anything to do with his varicosities?
Yes, ma'am. It can lead to failure of the ankylosing tendon to work, so which can predispose to formation of varicose.
And what else?
It can also lead to equinus deformity.
It can lead to failure of foot pump mechanism as far as the venous return is concerned. Like
Yes.
we talk about calf pump mechanism, there is a foot pump mechanism too, which is essential for starting the whole pumping sequence. So it
Yes.
starts with foot pump, then calf pump, then thigh pump.
Yes.
So though the ejection fraction of foot pump is minimum, just around 10%, and calf pump has maximum ejection fraction, but foot pump is the initiating process. So people with flat feet or collapsed arch have poor foot pump mechanism. So henceforth, go on observing the feet of your patients and you will realize how many patients with varicosities have flat feet. Do that.
Yes.
Yes.
Mohit,
Go
you
ahead.
mentioned about equinus deformity. So,
Yes, sir.
what is the significance of equinus deformity?
Sir, because of the pain, patient will like to prefer walking on the toes, which can lead and it will gradually lead to the fibrosis of the tendinoachilles tendon, so which can lead to the formation of equinus deformity.
Does that occur in each and every patient of varicose vein, or
No, no,
it
sir.
is a complication of complication? Which are the
Yes.
complications of varicose veins?
So, edema, pigmentation, eczema, ulceration, lipodermatosclerosis.
Ulceration. Where does the ulceration occurs?
So, near the medial malleoli, over the
Maybe
dorsum of the
medial,
foot
maybe
and
lateral.
lower
Huh?
leg.
Maybe medial, maybe lateral, but
Level. Yes.
those who are having ulcers, they are more prone to develop equinus deformity, not all.
Yes. Yes.
Carry on, describe inspectory findings.
Just a moment. We also welcome Dr. Nina Madam, Professor of Surgery at BJ Medical College.
Thank
Good
you.
morning, Ben.
Good
So,
morning. Good
madam,
morning.
good
Yeah.
Good
morning.
morning.
Mohit,
Please continue,
considering
Mohit.
the inspectory findings, what would you suspect? What is the source of development of these varicose veins on right side?
Source is a great saphenous vein with incompetent junction or valves.
And why not perforators?
Yes, sir. After examination, it can also be because of it can be because of perforation. Yes, sir. Perforating comments.
We'll discuss later. So you can continue, please.
But Mohit, to be on safer side, you should speak all. That is where Sujal has to ask again, no?
Yes.
All are
No,
responsible.
I want him to understand if there are
Yes.
only perforator incompetency, which is seen in 15% of patients, patients will
Ah.
have advanced disease on the foot, leg side, not foot. As sir said, gaiters area. And if it is descending theory coming from the SF junction, you will see classic varicosities. So those
Yes.
who have perforator incompetency, you will see by inspection that this patient has severely incompetent perforators. Those
Yes.
pigmentation, lipodermatosclerosis, and more of a edematous limb.
So Mohit, what the sir is saying that when chronic venous insufficiency, usually secondary varicose vein, and that mainly the perforators below knee are incompetent, and you will be able to judge from that. When limb is more or less normal, only visible veins are there, probability of it being SFJ incompetent is more likely.
Go to the inspectory finding slide,
Yeah.
previous.
Yes,
This
sir.
is just a pointer. Obviously, you
Yes.
will have to do the
Yes.
test to confirm it. One more point is that particularly when it is secondary and due to chronic venous insufficiency, visible veins are not that much. It is a more of a fibrosis with pigmentation.
No.
The veins may not be seen that much. That should be kept in mind, and with not a normal skin.
Yes.
Yes.
You have written on elevation dilated
ते ती
vein.
खिचडी काढून ठेवली का ग?
Yes, sir.
Is it really so? Each and every
आणि
vein disappears on elevation?
No, sir. In this patient, the dilated veins were getting disappeared.
Okay.
Mohit, what the
Mohit,
sir is asking,
Yes,
when
sir.
you elevate the limb, all veins disappear. The answer should be yes or
No,
no.
sir.
Getting
No, sir.
disappeared means what?
No, sir.
No. So what is meaning of no?
Sir, if in the presence of deep venous thrombosis,
No,
the
no,
veins
no.
will not.
We are talking of this patient. Sir
Yes,
is
sir.
asking because we are unable
This
to see
patient,
your elevation point. So when you elevate the limb, all visible veins disappear or not. I am not asking the cause.
Yes, sir. All dilated veins were disappeared on
Yes.
elevation.
Okay. Gunan bhai, anything you would like
Yeah,
to add?
suppose some of the veins are not getting disappeared or they
Hmm.
are still showing on even on elevation. What is your take?
Sir, it is suggestive of deep venous thrombosis.
Not deep venous thrombosis.
No.
Maybe
Is it
Superficial
not
thrombosis.
suggestive of
superficial
superficial
thrombosis.
venous thrombosis?
Yes.
Yes, sir.
Okay.
So it may suggest there can be a superficial venous thrombosis. Do you understand? You
Yes.
want to say patient of active deep vein thrombosis, vein may not disappear. But most of the
Yes.
time, patient you will get will have a chronic recanalized vein. So will the vein disappear with recanalized vein or not? They will. So, but if there is a superficial thrombosis, vein may not disappear.
Yes.
Next
And
slide.
in that case, you always palpate that and trace that vein. You may be able to palpate that thrombus. So most of the time, patient comes to the hospital when they have some trauma and then thrombosis into the vein. And because of that persistent vein, dilated vein, they can come to the hospital. Right? Okay.
Yes.
Next slide. Next. Next.
In palpation, temperature is normal and no tenderness. In Brody-Trendelenburg test, rapid filling of column of blood from about onwards was seen on releasing the tourniquet. And in test 2, gradual filling of blood was seen from below upward in below knee perforators. I have performed multiple tourniquet tests, which was suggestive of filling of veins visible at the site of below knee perforator, and modified Perthes test was negative. Lower limb pulsation was normal and no Brui heart.
You don't have to do any other test apart from these three?
So we can also do Morris's cuff impulse test and Fagan test.
What is Pratt test?
And so Schwartz test and Parts test, Pratt test can be done also.
Mhm. So what is your inference after Brody-Trendelenburg?
After Brody-Trendelenburg, it was suggestive of incompetence in the right siphonofemoral junction and Boyd's perforator.
Gradual filling from below upwards. Where does the location of boiled perforator is?
Below the knee, like, in the upper calf region.
So you have a SFJ incompetence and you have boiled perforator incompetence on bloody tunnel lumbar. Now, multiple tourniquet. Where do you tie the multiple tourniquets? Please mention.
So tourniquets are tied just below the siphonofemoral junction, above the knee, below the knee, and above the ankle. And
Yes.
it can also be applied at uh, uh, two places in the calf region to
Middle of the
identify
calf.
the leg
Middle of the
perforator.
leg. Yes.
Yes.
And
Yes.
in what
So,
order do you go on releasing the tourniquet?
From downward towards upside.
Okay.
first, you will have to observe with the tourniquets tied and patient in standing position.
Yes,
That
sir.
will show you the blowouts in those particular compartments in between the two tourniquets, right?
Yes, sir.
And then you start releasing the tourniquet from below upward. So in this case, is there any below knee perforators visible?
Yes, sir.
Which one? In
Sir,
multiple
this
tourniquet.
perforator.
In multiple tourniquet.
Yes, sir. These perforators were visible, sir, in photo.
Okay, and what about that middle of the calf?
So
Little bit.
that was, yes, sir. That, sir, no blowout was seen on some multiple tourniquet test in this perforator.
Okay. So at the end of these two tests, uh, give us your impression.
Sir, at the end of Brodie Danielberg test and multiple tourniquet test, my diagnosis is varicose vein involving the great saphenous vein with right
I
siphonofemoral
have
junction
great
complex. And
objection.
Same as
yes,
previous. Yes.
I have
yes,
great objection to his diagnosis starting with varicose veins.
right lower limb varicose
His,
vein.
his diagnosis or provisional diagnosis cannot say varicose veins. As I mentioned earlier, varicose veins is a manifestation of something else. So
Chronic
your
venous insufficiency.
diagnosis is not varicose veins.
Yes.
Your diagnosis is chronic venous insufficiency with right SFJ incompetence and according to you, right boiled perforator incompetence and whatever else. And you have to give CAP classification along with it.
Yes, ma'am.
Please remember,
Doctor,
varicose veins is not the diagnosis. Chronic venous insufficiency is the diagnosis.
What
Yes, ma'am.
about Perthes test? Have you done Perthes test?
Yes,
Yes, John is mentioned.
he
Yes,
has
ma'am.
written also.
So what is the
He written
difference between original
modified
Perthes
Perthes.
test and modified Perthes test?
Ma'am, in Perthes test, we empties the vein, and modified Perthes test, vein is not emptied.
Wrong.
Wrong.
And
Absolutely wrong.
Absolutely wrong.
yes, in Perthes test, we apply the elastic bandage from below upwards and then apply the tourniquet, and then we ask the patient to walk. And after removing the crepe bandage and after walking, there will be aggravation of the pain or prominent.
Sorry. You said after removing crepe bandage means what?
So first we applied crepe bandage to empty the vein or by
You are
the elevation of
remember
vein.
the primary thing, we do not empty vein in any kind of Perthes test. Whether
Any
it is a
Perthes test, yes.
we do not empty the vein.
Veins are never emptied.
So you are not elevating the limb, only applying the elastocrep bandage in original Perthes
In
test with
standing
tying
position.
above. And here you are tying with the patient standing. So time
Yeah.
required to assess the patient is reduced. That is the only advantage, right?
Yes.
Why do you want Perthes test?
To rule out deep venous thrombosis.
If patient is having deep venous thrombosis, is it having any change in your management?
Yes, ma'am. If the patient is then the varicose veins will be managed by conservative management.
Not always. Not always. If it is producing complication, you should assess patient after 10-15 years of DVT can be managed with perforator ligation and all these things, right? Okay.
Yes.
Anyway, the first reason is why Perthes test is done. What is the reason? Remember, it has a historic value. In absence of Doppler, we were not sure. Then the Perthes was very popular. Nowadays, I can understand. I don't know whether you have done it or not. Because we have straight away send the patient for Doppler. Go for a Doppler and you know about the status of deep vein.
Pankaj,
But
I never allow my resident to
that
sign
is a different.
application
He is
for
my
that.
resident. I never allow, but they don't do it. That's what the
Ah,
fact is. The point
no
here is that
Doppler.
why Perthes test? Why Perthes test? What do you want to see in a Perthes test?
To see whether the dilated veins are resolved on walking and there is no pain on walking.
So that is in a modified Perthes test. That is the biggest difference between Perthes and modified Perthes. In Perthes test, without emptying the vein, you apply elastocap and ask the patient to walk. The principle is then when you allow the elastocap, tie the elastocap, the superficial veins is collapsed. And if there is also presence of deep vein thrombosis, venous return is hampered significantly and patient will have an immediate pain. So it is in original Perthes, it is a pain perception by a patient that will tell you. But when you do modify Perthes test, you do not apply elastocrem. You tie without emptying the vein just below the SFJ and ask the patient to walk. So pain may be there, vein may become more prominent, may disappear, may remain static. And then, so you have a double advantage. That is the principally the difference between modified Perthes and Perthes test. You should always do before submitting the patient for a Doppler. What was the finding in this patient?
So, on walking, the veins got disappeared and
Pardon? What did you say?
Disappear.
patient
No, never disappears actually.
It is
But patient has no pain.
less prominent.
Yes. May become less prominent.
less. What had happened to your incompetent perforator when you did you Perthes test?
They have also become less prominent.
So how can you call it incompetent perforator? If it is an incompetent perforator, it may become more prominent ideally. So that is again a fallacy of modified Perthes test. It is an individual. But the main important point is presence of pain. Madam, would you like to add anything?
No, it's okay.
Okay. Sir?
Sir, this thing, what Dr. Mohit, what about Fegan's test? Is it? It's not important.
So Figan test is also important, but it can the defect in the deep fascia can also be dilated veins can also be perceived as a defect in deep fascia, so it can have false positive values.
In this patient, you have done or not? Pagan.
So I have done the test, but not much.
So
How you do it?
Yeah. How do you do it?
So first, in standing position, I will mark the position of the dilated veins, and after lying down and emptying of the vein, I will palpate the marked area, and I can feel the defect in the deep fascia.
No, I think you have to mark out the bulgings at
Bulges.
the or the
Yes.
bulges,
Or
the
we
prominent
call it as blowouts.
blowouts.
Yes.
So what is the advantage of doing Fagan's test, if at all? What is the advantage?
It can help in localization of perforators.
So how will it help?
During surgery, if the perforators are not
No,
along
forget
the
about surgery. Surgery comes very late. We are not talking of surgery. So how will you do multiple tourniquet test?
Sir, I will apply tourniquets just below the sacrofermoral junction, above the knee, below the
The
knee,
point is that
in
Fagan
mid-leg, and
test may help you to localize the incompetent perforator, probably. Do you understand? So when you mark
yes,
by
sir.
Fagan test with the defect in deep fascia, you can apply multiple toning above and below it. So that may
Yes.
help you. That is the advantage of Fagan says. Sir, would you like to add anything?
Your
Go on, madam.
palpation in Fagan should be along the course of GSV.
Yes.
I
Okay.
may not agree with you there because actually perforators are along the posterior tributary of the GSV. And again, as Mohit mentioned earlier, Fagans has a lot of false positives. So Fagans is
Yes, yes.
almost gone up by Fagan himself. And it's not really a good test to give you any great idea.
Yes, the most of the surgeons don't do
That
it.
is
The
true,
reason is
madam.
that because
In fact,
even
most of the surgeons are not doing any
not
test.
doing.
They are
Yes.
just looking at the legs and sending the patient to radiologist, which is a
Madam,
sad
but
part.
Fagan test, which Fagan himself was doing, was done along the course of GSV. Yes, I agree with you that some posteromedial tributaries, they have perforators. That is a different story. Okay.
Okay. Anybody would like to ask anything about palpation, madam?
What about SP junction?
Yes.
Have examined the SP junction, either inspection or palpation. This thing. Is
Yes,
there
sir. I
any?
have examined in the inspection and palpation. There was no blowout or visible vein were present in the popliteal fossa and above it.
What else will you palpate when you are doing palpation?
I will look for palpable thrill or cuff impulse in the groin region.
Forget that your venous examination is over. Now, what else will you palpate?
Pulsation.
So, arterial pulsations, it's an essential part of the examination.
You must.
Yes.
You must palpate arterial pulsations.
As well, lymph node palpation is also important at SF junction. If
And
there is a very
continuing
large lymph
upwards
node
abdominal palpation.
and abdominal. Yes.
Yes.
In case of
Yeah.
venous insufficiency, edema examination for the edema along the sheen of tibia and especially ankle area gives some idea about perforator incompetency. So, and vitamin D3 deficiency, you should also suspect if somebody has persistent edema. So keep in mind that point.
Yes, sir.
Okay.
Why did you say no bruit heard? What do you mean by that?
So, bruit can be seen in the patient with
What you have written here?
so no bruit heard.
Where? That's what I'm asking you.
Sir, in sir,
Auscultation.
near the syphilis opening in the
From this bruit, I understand in heart.
yes, sir. So no
Where do
bruit
you
heard.
look for a bruit?
So I will
Bruits
look
are
near.
generally, Mohit, bruits are palpated and murmurs are heard. Auscultation, you hear the murmur, not the bruit. And where do you look for bruit?
Near the syphilis opening, uh, 4 centimeter below and lateral to pubic tuber.
So first you will speak about this FN varix. Is it seen or not when you are mentioning about bruit?
So
Okay.
are there a bunch of vein at SFJ?
No, sir.
So how will you hear the bruit?
Venous thrill or venous hum is different from bruit.
Yes.
Yes. And be specific. Only if it is present, then only mention it. It is very
Yes.
rare to hear the bruit, usually AV malformation or very large varicose bunch at the level of SFJ. You may be, same thing goes for tapping test, impulse on cuffing. So
Right.
you have not mentioned anything about that, and why you are mentioning about bruit?
Yes, sir.
Bruit will give you idea about secondary varicose vein if there is arteriovenous fissula at SF junction adductor canal. It is very common. Very common means those person who have stab injury or bullet injury, patient will present with varicose veins but advanced disease, and you may miss the if you miss the IAV communication, the whole procedure will fail and it will keep on recurring.
Yes, yes.
Yes. So in those
So
specific cases,
I was just one. I was called at Mehsana for one case. Patient was on table and just I started talking with the patient. There was a thrill on the thigh. And then the whole procedure was cancelled because somebody had posted it for varicose vein RFS, sclero, and phlebectomy, and patient had a deep AV fistula. So we had to repair that, disconnect that, and then do the varicose vein treatment.
So see the significance of clinical examination in the era of Doppler.
Yes.
Next slide.
In systemic examination, per abdomen is soft, non-tender with no dilated veins in lower abdomen and no lump palpable. The CNS and respiratory system are normal. In summary, 35-year male security guard by profession presented with a complaint of dull aching pain in with dilated veins over right lower limb for 6 years, aggravated by prolonged standing and relieved by lying down with no operative history. Now, on examination, there are dilated veins along the medial aspect of right thigh and leg with right SFJ incompetence on Brody test and Boyd's perforator incompetence on multiple tourniquet test. In diagnosis, where 35-year-old male patient with varicose vein in the right lower limb of primary etiology involving great saphenous vein with saphenofemoral incompetence and void perforator incompetence without any complication. My CEP classification is C2 EP ASPPR.
How will you investigate this patient?
I would like to go for complete blood count and renal function and liver function test for the assessing the
But
fitness
you
of the
don't
patient.
want to confirm your diagnosis?
Yes, ma'am.
Oh,
For the
yes,
confirmation
next
of
slide.
diagnosis, I would like to go for
So that is the first
duplex scanning.
investigation, no?
Yes.
In next slide, I think you have mentioned, no? Next slide.
Yes.
No, duplex scan is not mentioned here. Yes.
Yeah.
You have done it and you have seen it. Okay, so what is duplex scan and Doppler?
Duplex scan is a combination of B mode ultrasound with Doppler, and Doppler is the change in the wavelength of the waves due to moving objects.
So why B mode images are required in such
So,
cases?
so B mode images are required to look for the diameter of the vein, the content of the vein, and its distensibility. And a Doppler is required for the velocity of the blood and direction of the blood flow. And the presence of reflux.
One more thing in duplex scan, there is omitting the bone. In duplex
Yes.
scan, bones are not same. That is the main advantage of duplex scan. What is the disadvantage of duplex scan?
It will require the cooperation of the patient during the doing the Valsalva maneuver or holding breath.
No, disadvantage. That is not.
Disadvantage.
It will have a high inter-operator variability.
Yes, that is one thing.
That is one. And second is it shows red color blood for in a patient who is having blood away from the heart and the blue for going towards the heart. But if there is a fistula, AV fistula, this will differ. That is
Yes.
the main disadvantage. Okay.
Yes.
In what position do you do this duplex ultrasound?
Ma'am, in standing position.
You're saying
Yes.
that how many patients have you seen coming with a report done in standing position? Or if you ask the patient, you have to confirm it with the patient,
Ma'am,
whether
I
it
have
was done in standing or in lying down.
confirmed with the patient with standing and also lying down. Patient was examined.
Which
Mohit,
veins
have
do
you
you
heard
examine
about
in
May-Turner
standing and
syndrome?
which ones in
Sorry.
lying
Yes,
down?
sir.
Sorry, madam. Please continue.
No, go ahead.
I just asked about May-Turner syndrome. Have you heard about it?
Yes, sir.
What is
S- uh,
that?
s- Sir, it is a compression of the left common iliac vein by the right common iliac artery, leading to May Turner syndrome.
No,
Is the
leading to
significance?
venous hypertension and
Venous
venous
hypertension in
insufficiency on
left
left
lobe.
side.
Yes,
Left
sir.
side, yes. That is the
So
significance of.
your Doppler may not
Yes.
be confirmatory if patient has compression at that level. Even CT venography or CT angiography may not show an intravascular ultrasound. IVUS is the diagnostic scan for such patients. So that is one more limitation of duplex or Doppler, what madam asked. You may not be able to diagnose the cause which are in abdomen. Below inguinal ligament, Doppler is excellent, but the
Yeah.
proximal part may not be clearly diagnosed. So if somebody has advanced disease, or if superficial veins are treated but the patient is not relieved and there is no DVT, you should think of May-Turner syndrome.
Yes.
Yes.
I would probably add, Dr. Shah, that you should think of deep venous problem, not only May Turner, but other problems also.
Yeah.
Yes.
If patient comes with recurrence despite previous treatment.
But madam, deep venous thrombus and DVT or its sequel can be diagnosed on Doppler. Abdominal veins will show either occluded or recanalized veins. But even
Yeah,
if they
but
are very normal, they will look very thin and phasicity will be there, compressible veins, but there is compression. So in
yeah,
CEAP, reflux bar obstruction, there will be obstructive component and reflux component both from
I agree.
the abdomen part.
I agree. But Doppler done in supine position only can miss a number of SF junction refluxes.
Absolutely. One more thing, room ambience and temperature also matters. If it is done in very cold room and the patient is very sensitive, you will get wrong diameters of the veins, GSV and all. So the temperature and room ambience should be very comfortable to the patient.
Correct. And I don't know what is your observation, but my observation is most of the radiologists prefer to do Doppler ultrasound in supine position. They don't do it in standing position despite writing it on the paper. Because
A good
doing it
radiologist
in
will always,
standing position is rather difficult and time consuming as compared to supine position.
but venous Doppler has to be done in both, madam. Standing is must for
No,
varicose
it
veins.
has. I do venous Doppler of my own patients.
Yeah.
So I know that radiologists
We
do it
always
in
do it in
supine.
standing in our
I
hospital.
always do it in standing as well as supine.
Yes, yes. Agree.
Most important thing, madam, is you should give enough time for venous Doppler to do it. Whosoever is doing it, it should never be done in hurry.
Mohit, what about the classification you have written? Can you elaborate a little on that?
Apurva,
Yes, sir.
Apurva,
Sir.
this is the report of Doppler. Do you agree with these reports, sir, madam? Because it is far cry from your clinical diagnosis.
Yes, yes.
Because this is a very common problem faced every day by all the vascular surgeon and general surgeon. So why there are so many incompetent perforators seen on Doppler?
Because the increase, it's a defect in the deep fascia and a dilated buffer. Normal buffer will also be seen as a dilated during examination by Doppler. So they will
What are
perceive it
these
as
perforators
incompetent.
called? What are these the normal but dilated perforators called? They're
I
called
don't
as
know.
re-entry perforators
Yes.
because they are just trying to bring the blood back. So they are dilated because there is more blood as there is reflux in the superficial system. That blood has to go back to the deep system, and so these perforators are dilated so as to return the excess blood to deep system. So they are called as re-entry perforators. They'll become normal in size once you control the SF junction incompetence.
Yeah. So that is actually not an incompetent perforator, they are dilated perforator, it should be said. So that is the another important significance of clinical examination. right? So we usually send the patient for a marking of perforator, and he comes back with all this marked perforator. Will you treat them or not?
No, sir.
No.
I will not treat them.
So Srujal, it's a question for you. Should we believe
Yes, sir.
Doppler every time?
Yes, sir. So my decision for treat is more or less based on clinical examination. Doppler is just done for confirmation and further process, and for sometimes documentation purpose. So
And
treat
because
and
it is needed by insurance company.
That is a document.
yes, ma'am. So exactly the same. So and second thing, as you said, sir, mentioning lot many perforators, this report is very much misleading to many or junior consultants or
Yes,
you know those who are not very much expert. Here you all are so focused on the report, I mean on the varicose vein. We could point out this problem with you know radiologist also, but it should be informed to them. Hello, am I audible?
Yeah,
Yes,
yes.
Yes,
Yeah,
yes.
you
Yes,
are.
it should be discussed with the radiologist also whenever we find such report that they should start mentioning entry perforator or exit perforator, and it will guide us.
I think we lost him.
Yes, yes, we lost him.
It's okay. But remember, so what is the biggest advantage of doing Doppler? Why it is must, apart from documentation and that, Mohit?
To rule out deep venous thrombosis.
Remember, yes. So a deep venous thrombosis, it is important. What will you see in Doppler in a deep vein thrombosis? Apart from what we have already discussed. So it can be acute or chronic. We are more concerned with the chronic. So what will you see in that case?
So during chronic case, I will look for a recanalization of the vein has been occurred, which can lead to valve damage.
Right. Can you see it in Doppler? Difficult.
I don't know.
Difficult.
Yes.
So
Yes.
because the Doppler measures the flow. So
Yes.
sometimes once the recanalization has occurred, it is difficult, but some good radiologists can tell you whether it is a recanalized vein or teno. Yes.
In
If
case of
Yes,
If
sir.
radiologist,
yes.
if radiologist is doing it sequentially every month, that Doppler study, they can mention from that flow that it is recanalized. Otherwise, for doing for the first time, they cannot say it is recanalized, right?
That
Sir,
depends
you were
upon
saying
expertise and
something?
experience. Yes.
yes,
Yes.
Dr. Mohit, in
Otherwise,
venous
back.
duplex scan, no,
Yes, sir.
see, even after this chronic recanalization, no, what you can observe is the reflex at that damaged wall. Radiologist, they'll mention you have to ask for is there any reflex across the walls? That may be the indirect evidence of your damaged wall, secondary or DVT.
Yes.
Agreed,
Post
sir.
DVT.
And other two evidences could be thickening of the vein,
Vein, yes.
thickening of the vein wall, and sometimes you see residual thrombus in the deep veins. It is
Ah.
not completely
Partial
resolved.
thrombus can be seen
So
sometimes at the
these
places,
things
which
can
can
be
help you.
detected on Doppler.
Yeah.
Yes.
And the history will again be very important. A patient who had a history might be suggestive of DVT can help. ગુણવંતભાઈ કઈ પૂછવું છે એમાં?
Yes, I want to ask actually Sujal bhai. Sometimes they mention the reflux, but what actually reflux means on duplex, and is there any importance of time period or duration of reflux in Doppler?
I
In
think
duplex?
severe reflux will be significant reflux will be more than 3 seconds. That from SF junction.
So
So
that is
No, I object. I object. Significant reflux is more than half a second, more than 0.5 second. While in perforator, yes, I agree with you that in perforator more than 0.3 seconds is considered significant. In deep vein, more than 1 second is considered as significant.
SF junction.
SF junction is more than 0.5 seconds.
0.5 or 0.3, I think.
0.5.
Yes.
And the diameter has nothing to do with reflux. Reflux is separate entity, velocity is separate entity, diameter is separate entity. But diameter does not decide that there is reflux. Because quite
Madam,
often I see that the diameter is more than 0.5 millimeter, more than 5 millimeters. So there is reflux. No, that is not. The reflux has to be for more than 0.5 seconds. The velocity should be more than 20 centimeters per
second.
second.
Madam, do we decide treatment on based on diameter of the perforator?
No.
Definitely.
Perforator diameter, yes, but not
Yes.
GSV.
Perforators.
Perforator diameter, I agree.
Because here
but
he has
not
mentioned
GSV.
4.3, 5.
No, so that's okay, but not for GSV.
We usually don't treat perforator, sir. We stop the reflux which
Exactly.
is coming from axial vein, and then
Yes.
superficial vein above the perforator is once you sclero them. So we don't want the sclerosant to go into the perforator to close them, because if somebody has so much refluxing perforators, the skin will be bad. So we
Yeah.
cannot just keep on injecting there.
I think one indication for closing perforator is active ulcer.
Yes.
Mhm.
But then sclerosant won't be sufficient. So either you do laser or RF, or you just ligate
Whatever,
them.
but means you treat perforator.
But still, after treating them, we would advise them for compression for lifetime, madam. So
That
anyway,
is
even if you
agreed.
don't treat those perforators, compression will be taking care of them.
So the point is there should be a reflux, Mohit. That is the basic point. If the
Yes.
reflux is there, it should be treated. If no reflux, that is a okay.
Yes.
That's what I understand.
So as per Madam said, all three things are important. But and the treatment part, Sujal bhai said ablation should be done. What about primary stripping of GSV instead of perforator ligation?
In conventional surgery.
Yes.
Yes. Sir,
Something
by
like
primary stripping of great saphenous vein, it will decrease the recurrence rate.
in the treatment of ulcer, Madam said, no? Suppose your
About
patient has
I was
ulcer.
talking about perforators.
Perforator ligation or ablation has been supposed to help in the improvement in the ulcer healing and will lead to decreased recurrence of ulcer rate.
Gore, Madam.
As I mentioned, if there is an active ulcer, I would prefer to do treatment of refractive perforators. By what method, that depends on individual. But SEPs personally, I've given up long back, and many people have given up long back. It is better to use one of the endovenous procedures for perforator too. Either though Dr. Shah seems to be against sclerotherapy, one can use sclerosant to do that. One can use glue to ablate the perforator, or one can use laser ablation for perforator ablation also.
Mohit, there is a
Yes, sir.
one thing written in this report. What is significant? Vein of Giacometti.
So, vein of Giacometti is a cranial extension of the popliteal vein. If it is persistent, it can lead to recurrence of varicose vein.
How will you manage it?
It is short saphenous vein, not popliteal vein.
Popliteal
Yes,
vein.
yes, sir. Sorry,
SSV.
sir. Short saphenous.
It's a short saphenous, yes.
Yes, yes.
Superficial, not
And
deep.
if I may add,
Where will you see? Where will you see?
In the popliteal fossa and posterior aspect of thigh.
So in the thigh, posterior part
Yes,
of the thigh. Okay.
yes.
if
Madam,
I
you
may
were asking something.
No, I just wanted to mention that the term vein of Giacometti has now been given up in new nomenclature of veins, and it is, as Mohit said, it is called as cranial extension only, not vein of Giacometti any longer. And what is important is one needs to see where it is going and in which vein is it opening cranially, whether it is going to femoral vein or it is going to GSV, because depending on that, one may have to plan the treatment. I have seen cranial extensions opening into GSV, and GSV is also refluxing. So cranial extension is also refluxing. So actually stopping the reflux in GSV itself is quite often enough to stop the reflux in cranial extension. So one has to really do the Doppler in appropriate way to find these various locations of opening of cranial extension.
Yeah. Is it visible in this patient, though they have written in Doppler?
No, sir.
It's not visible.
Posterior, you are having posterior picture of this patient, no?
Yes, sir.
Not visible.
It's not visible. Fine. So what does it suggest? Probably it is not opening in GSV and maybe not refluxing.
Or it is not refluxing
It
simply.
is not refluxing. That is
Yes.
the point it says. That is the significance of what was previously, as Madam has said, vein of geoeconomy.
Okay.
Right. The importance is, if it is untreated, can lead to recurrence. That is the important point. You should keep it in mind. Gunon bhai.
Yes, Mohit, now you have done Doppler and all other investigations. What would be your line of treatment in this case?
Sir, I would like to post this patient for SFJ flush ligation with GSV stripping.
Okay, I agree with you. Any other examiners, Gore madam?
Yeah, I mean that is a treatment that we have been doing for a number of years and still have to do at certain places and with certain patients. So that's fine, but what precautions or what particular methodology do you follow when you are doing this surgical procedure?
Preoperatively, I will go for marking of the siphonofemoral junction and the perforator, incompetent
Okay.
perforators.
Oh, I think let's forget about the perforators for the time being. Let us talk
Yes.
about SF ligation.
Yes, ma'am. Ma'am, after preoperative marking, and I will keep the oblique incision along the inguinal region and just up to the femoral pulsation. I would like to identify all the tributaries entering into the vein, and I will ligate.
Why are you marking the SF junction if you're going to take such a long incision? What will be the
Mohit,
length
you
of your
understand? Mohit, you understand the question?
Yes, yes, sir. So for ma'am, for proper identification of the position of the junction, I will.
But you have
So
marked the junction, no?
yes,
SF
ma'am.
junction is always constant, need not mark.
Yes, ma'am. Yeah.
Because once you palpate the femoral artery, it is just medial to it, right?
Yeah. Yes,
So
ma'am.
not required all the times.
Where is SFJ? Anatomical definition.
Siphonofemoral junction is present 4 centimeter lateral and below to the pubic tubercle.
Which fascia?
Cribriform fascia.
Which fossa?
Fossa ovalis.
And how does it enter into the femoral vein? What angle?
Acute angles.
Yes. So these anatomical landmarks are almost constant that Dr. Mudiswarya said, no? So there is
Yes,
no
sir.
need to mark and you are taking such a long incision. So
Yes.
what is most important is to ligate each and every small or large tributaries entering into GSV in that area. So which are the tributaries?
So superficial circumflex iliac, superficial epigastric, and superficial external pudendal are
So
the
in
three
answer,
constant.
you have to say from medial to lateral. That is most important thing,
Yes.
right?
Yes, ma'am. Yes, ma'am.
Why do you want to ligate this tributary? What
Ma'am,
happens if you do not ligate?
it will lead to the development of recurrence and siphena varix.
Recurrence is very common after missed tributary, or even if you have not missed the tributaries, there is something called uh, neovascularization or new development.
Yes.
Okay.
Can I
Will you?
mention one point?
Yes, ma'am.
If you have marked the SF junction You
Yes.
know the exact location, though
Yes,
we
ma'am.
know that the landmarks do give us the location. Your
Yes.
incision should be just about 2 centimeters, because
Yes.
longer the incision, more are the lymphatics that you are damaging,
Mm.
and more is the chance of post-operative either
Mhm.
lymphoria from the incision or lymphedema in the leg over a period of time. So
Yes.
please take a small incision just over the SF junction, ligate tributaries, ligate that, and what else is the important part of Trendelenburg's operation
Flush
besides
ligation.
ligation?
Flush ligation.
And
Ligation done. What else is
and
important?
after
Stripping of the
ligation,
great stiffness,
Extra
ma'am.
flush ligation.
Stripping and
Stripping.
stripping. Yes.
Yeah.
So how do you strip it, and to what an extent you strip?
Uh, stripping is done by the cordman stripper. It is done up to the level of just below the knee in upper cuff region.
okay, agree. Why below the knee only?
Because after distal to the upper calf region, the great stiffness vein lies in close relation with stiffness nerve. So the chances of nerve
Hmm.
injury will be more if we'll
Okay.
strip from below knee.
Hmm. Okay.
What is the supply of this now?
Sorry, ma'am.
This now supplies which region?
Over the dorsum of the foot and the medial aspect of the thigh and leg.
Thigh?
Not thigh.
Not thigh. We
Leg.
are talking about stripping.
Foot.
So injury will be lower down.
Leg and
You
foot.
say
Leg and
dorsum
foot.
and
In a leg
medial.
and dorsum. Yes.
Yes.
Rizal, one question for you. Where does stripping stand at present? And have you done any stripping in the last couple of years, being a vascular surgeon?
Sir, I've done only one stripping in last 15 years. That was in first year of my practice.
Wow.
So,
Srijal,
and
my God,
varicose vein
we
number
are
would be in
still
thousand. So it is
learning
actually
it.
No.
we get the same good result with laser, RF, glue, all the modalities. So we don't do stripping. If the vein is quite big, like for example 2 centimeter or something
Yes,
like that,
yes.
we may have to offer it.
Okay. Gora ma'am, with your experience?
Almost similar like Dr. Shah. And I do agree with him that if the vein is, if SF junction is too wide, I may think of ligating SF junction and then maybe do laser ablation of rest of the GSV. But that is very
Okay.
rare. I have been able to successfully ablate a large SF junction to the extent of about 1.9 centimeters.
Okay. Okay.
Apurva.
Yes, sir.
So I have a question for you also, because we have 10 surgical units in our institute and I have 6 surgical units in my institute. We don't have laser or RFA, and we are still doing stripping and
With
performing.
excellent results. With
What is your
excellent results.
experience? What is your experience, Apurva? And
Why,
Nina Ben
sir?
also.
I mean, of course, laser and everything is there, but the next day the patient goes home. The only thing we do, because it's an institute, we do it under spinal anesthesia, or you can do it. You can do it in a local also or a short G also.
You do
The
laser
only issue is,
and RFA, Apurva?
yes, sir.
You do laser or RFA?
No, no, we do stripping only,
Open
and we
stripping.
are. I mean, and sir, we are really happy with the results. Considering
Yes.
that it's the patient goes home the next day morning, and I am yet to see any lymphedema, lymphoria, or saphenous nerve damage.
After this surgery, yes.
Yes, sir. So okay. Uh,
Uh, Dr. Mohit,
yes, sir.
if the patient would have been like with lipodermatous sclerosis with ulcer,
Yes, sir.
so will you manage like this? What is your management
Sir,
with this
if there is
patient?
a Sir, if there is ulcer is not infective, I would like to operate the patient with the same Trendelenburg operation. If the ulcer is infective or spreading, I will treat the ulcer first by compression dressing and elevation of the limb and crepe bandage application.
I
Now,
will again say, is there any, most of the time there is no infection in the ulcer. So it is out of
Agree.
question, right?
now will you
Yes.
do stripping? Stripping and all you do here in the leg.
Yes.
What about the patient who has got perforators in the leg with lipodermatosclerosis with ulcer and SF junction is incompetent? Is
Yes,
there any other modalities?
so other modalities will be perforator ligation, sir.
How is
With the
this?
Or even sclero.
sclerosis.
Because
Yes.
when the patient has got
Endoscopic
lipodermatosclerosis,
steps you have to think.
Yes.
one is endoscopic, other endovenous, as madam told, like endovenous lasers.
Yes.
Sir, is there any role of RF in case of
Yeah, that
perforator,
is
sir?
what Madam, Dr. Gore and Dr. Shujalbhai, any role of, I mean, what is the difference between RFI and laser? And I think everybody does laser, RFI is being pushed aside. Can you just give some finer points, please?
Okay. So technically speaking, RFA and both are endovenous thermal ablation, EVTA, endovenous it uses the principle of heat. RF cuts off at 120 degrees centigrade, while laser, certain machines can go up to 200 to 300. So that is one difference. Second thing, technically success rate is 98% for both. So long-term recanalization is seen in 2% of patients in both the modalities. So it is depending on your training and your preference. RF, certain people are trained with RF, and then I use exclusively RF. I have laser machines but use RF more because it is safer for those patients where GSV is very near to the skin. So the chances of skin burns or any perivenous damage by heat are less with RFA. That's what I feel. Otherwise, both are same. Second thing, coming to the below knee perforator part, both the technologies have catheters for perforators. RF has a catheter of 3 centimeter. Laser also has a tip-based catheter which can ablate the perforator. But very few centers and very few vascular surgeons are doing that. Not all people treat perforators with these devices.
Okay.
I have one more point to add.
Yes,
I
ma'am.
think one is finances. If somebody has a laser machine, I'm happy that Dr. Shah is able to have all the thermal ablation equipments, but
Yeah.
it may not be possible for everyone to purchase both radio frequency machine as well as laser machine. So you probably end up having one machine, and so you continue to use that. Secondly, in my experience, I've used both machines. I've done both radio frequency ablations as well as lasers, but I find laser fiber being little slimmer than the RF catheter. If the vein is tortuous a bit, manipulation of laser fiber through that tortuous vein is little more easier than the RFA fiber, where the terminal 7 centimeters are very rigid. So I mean, that's very part of the machine. You can't do anything to that. So manipulating that rigid part of the RFA catheter is challenging through a somewhat tortuous GSV if it is still within the facial compartment.
Yeah. So where there is a kink or curve, you have to
Yeah.
manipulate with the pressure and
Yes, you
pull
have
and
to
push
do
method.
either tumescence or pressure or some
Yeah.
such thing you have to do, which is
That's
easier to
what.
do with laser fiber.
Yeah. So sometimes we take two punctures. If the vein is
Yeah,
kinking, changing the direction, I take
yeah.
two
I mean,
punctures.
I prefer
Yeah.
to do that if pressure and this thing doesn't work, I simply puncture the vein again at the top of the kink.
So
Right.
my purpose of buying the laser machine was mainly for spider veins. We do diode laser for certain spider veins cosmetic part. So for that, RF doesn't have good machines. So
No.
we took laser, and that has the laser 1470 endovenous laser also. So
Yeah.
surface laser with endovenous laser. Otherwise,
Yes.
one machine is good enough for your practice.
Otherwise, I
Uh,
mean, RF is a simpler technology because you don't really have to do anything. The machine gives you the signal that, okay, you have done enough.
Done.
So that is easier.
Okay. One more thing for postgraduate, the role of tumescence anesthesia. I mean, do you throughout the vein you do it or
It has to
Always,
be done throughout, sir. From
always.
puncture to SF junction.
okay, okay,
And
It
I do
creates,
and
all
you
for
my
use
Mohit,
yeah.
Yes, sir.
yes,
it creates a, see, it is an important question for your exam. It creates perivenous heat sink and collapses the vein. So the fiber will come in direct contact with the venous wall and heat will denature the vein very nicely. So it doesn't have to be in subcutaneous plane. It should go into the saphenous fascia, saphenous compartment, where you see the saphenous eye and then you keep on injecting the fluid. So that helps in successful outcome.
Yes.
And I do all my cases under local anesthesia with tumescence because the tumescence contains local anesthetic agent.
Yes.
right,
You don't need to give any, you don't really need anesthetist services for that.
right, right.
Okay. Mohit, what is the role of foam sclerotherapy or sclerotherapy in varicosities?
Yes. So
When
foam sclerotherapy is used for the dilated perforators, and it will increase the surface area, to do which there will be more contact of the sclerosant agent with the blood wall, venous wall. So it will be fibrosis of the wall occurs because of endothelial damage.
How will you prepare
is
it? How will you prepare
It
it?
It will be prepared by Tessari technique by taking a three-way cannula and two syringes. One is filled with air and one is filled with the sclerosant agent. It will be taken in the proportion of 1:3 or 1:4, and there will be 5 to 10 times mixing in the three-way column will be done to make the foam.
Why do you want foam sclerosing? Why not straightforward injecting the sclerosant?
A straightaway injection of sclerosant will get deactivated by the presence of blood. So to displace the blood and increase the surface area of contact with the wall, I will make the foam.
Mohit, do you know any recent methods of sclerotherapy?
Yes, so endovenous sclerotherapy, ESV, by
All
which
are
the
endogenous.
USG guided, I will go and give the sclerosant agent to ablate the great saphenous vein.
No, when you do it under USG guidance, it is known as ecosclero. But what is MOCA?
Sorry, sir.
MOCA.
MOCA, MOC. Actually, I was
MOCE.
going to ask that to Shrujal or Gorem ma'am, but
Yes.
Mohit, please answer, and that will be completed by them.
If you don't know, we have experts to answer.
No, no, he should know.
He
He
should
should
know,
know
yes.
something about it.
It
Yes,
is a MS question.
yes, sir.
So,
MOCA, MOCA, beta.
so mechanico-chemical ablation technique.
Yes, yes.
Mechanical
What is it?
occlusion, chemical ablation.
Yes.
MOCA.
Yes, sir.
CA is your sclerotherapy. MO
Yes.
is your rotating needle or scratching
Yes.
needle will damage the endothelium and then sclerosant will further improve the ablation. So it's a
Yes.
mechanical plus chemical damage to the vein.
Yes, sir.
So,
Clarivan
Shrujal
is
bhai and
the
Gorem ma'am,
Yes.
where does it stand? Does it, I mean, is there any
Uh,
standing or it's just to complete the list?
I I personally think that it has not become so very popular. One reason probably is because of the cost, and personally I don't I don't like the methodology. Simply, I don't like to scratch anybody or anywhere.
And maybe, madam, because of success of laser and RFA both. Rest
Shrujal
of
bhai,
it
your
I,
take?
not required.
maybe
Shrujal, what's
I
your
don't
take
know
on
what is
MOCA?
Dr. Shah's opinion.
Yeah,
Clarivan or this MOCA is actually, see, everybody tries to do something new, and that's why this
I
came into
know.
the market and
Yeah.
it is there with certain places, but it is not practically
It is
better
not,
than laser or RF.
and it is not
okay.
so very routinely used as other thermal
Yes,
methods
yes,
and
yes, yes.
We do
Ultimately,
two
it
to
is
three
sclerotherapy.
cases with all new devices and then choose whatever is best in our hands. So
naturally.
still,
Right,
Agree.
right. Okay, Shrujal bhai, just one recent advance if it is there. because I had done this microwave therapy. I did something for thyroid and everything. Do we have anything for varicose, or it is still in
Yes,
pipeline?
yes, yes.
What is that micro? There is a lot of
Microwave.
Microwave,
noise.
Sorry,
Microwave.
microwave. Yeah.
Yeah,
microwave
Because
ablation.
it
nowadays
is
there is a
there.
way. See, for benign lesions, I had trained myself in thyroid and all those things. So, is there anything coming up?
It is there,
Same
sir.
machine.
Microwave machine is there, but not very,
Okay.
again, same thing. When you have best things, easiest and best, most effective things, no other devices will score over them.
Work. Okay. Right.
But I think
Yes,
if you
ma'am.
have a center where somebody is doing vein, somebody is doing other organ ablation with microwave, then it is worth purchasing a microwave equipment to use it for all these purposes together.
Right. Right. Gunadbhai, sir. Rathod sir.
Okay.
Dr. Shah, I just want to know your opinion about the cyanoacrylate glue ablation.
Yeah. So it's a technically speaking, success rate is good, madam, but you must have heard about the allergic or
Yeah, embolism.
those reactions which are not
Yeah,
justified for varicose cases like varicose vein. Varicose vein are not life threatening where you want to take
exactly.
7% complication.
I
And
know.
when and it is not safe in 100% of patients where laser RF
Agree.
stripping safe.
Agree.
So
And
people
in
do it by marketing,
oh
and the companies
yes,
are also
that is
pushing.
just too much. Yes.
Yeah, I
And
have
apart
seen.
from that, yeah, apart from that, my impression is that it is all right for a small size vein, probably 5 millimeters or something. But when
The
we
one,
have large veins, 7, 8, 9 millimeter size, then it doesn't really work as effectively.
the important thing here is, madam, who will develop hypersensitivity, we cannot predict. So,
No, and you
and
can't
it
test
comes
also.
after 1 to 2 weeks. And I have seen patients coming with a limping and whole thrombophlebitic red vein, and then you have to take out that vein.
It's horrible. It's horrible.
It's
I
horrible,
understand.
and it spoils the name of disease and surgeon both. So we should not, until unless it is 100% safe, committed by the company, we cannot promote it.
Yes, I use a cyanoacrylate glue, but particularly in patients with anomalies like clipple trinoni, some areas are really huge. I mean, the channels or the lakes are really big ones. So I just inject cyanoacrylate glue in those lakes to close them before excising them because then the blood loss becomes much less. Because some patients I have had who have these anomalies affecting even the vulva. So excising that part becomes much easier if it is
Yeah.
already closed using
Thrombosed, yes.
cyanoacrylate glue locally.
So there is a very interesting paper by Parsi et al. Who has mentioned 13 death strokes. So
Oh,
it is not justified for varicose vein patients.
yeah, I'm
Yes,
I'm
yes,
not
yes.
at all fond of glue.
Yeah.
Yes,
Rathod sir.
Mohit,
Yes, sir.
you have any questions
No,
which
sir.
are unanswered? If you feel like you can ask,
Yeah, we have all the experts with us.
otherwise we can conclude.
Yeah.
Sir,
Neena ma'am.
Just one suggestion to Mohit.
Yes, ma'am.
You
yes,
have given us your diagnosis and you have mentioned that it is C2 and rest of the things, but you
yes, sir.
must know the complete CEAP classification
Yes,
because
ma'am.
today we did not ask you CEAP classification, but you should know the latest modification also of CEAP classification. Okay,
Yes,
so please remember and read it.
yes, ma'am.
Okay. Because that is the only way by which you can communicate your information with somebody
I,
else on the
I
same
think, ma'am, we
platform.
can conclude with the classification itself. We'll just allow him to
Yeah,
conclude with the
let
classification.
him give
Mohit,
us
just,
CAP
Yes,
classification.
yeah, just give
One,
the
yes,
CAP classification, then we'll close the call.
yes,
Yes,
sir, one
Sujal.
point.
Yes, sir. Sorry. Yes, sir.
And none, I
His
think.
his patient has some pigmentation on the posteromedial calf, and the classification, his diagnosis will change from C2 to C2 and 4. Just
yes,
go to the
Oh,
clinical diagnosis, the
Yes,
clinical
yes,
picture
I
slide.
think yes, I think he
yes,
has
sir.
mentioned CAP.
no,
So,
he
Yes,
has
Mohit, put up
written
the picture
C2.
and tell the
He has just
classification, then
written
describe the
C2.
classification.
Yeah.
yes, sir.
Your third or fourth slide had the leg picture. There was
Yes,
some
yes, sir.
pigment patch. Can you just go there?
Yes, sir.
So if you, what is this on the calf? Have you marked something? No, no, the first image. First one.
Yes.
On the left side. Zoom it on the left side.
This.
The other one.
Yeah. What is this? Is it marking or what?
This.
I think it is
Yes.
marking ink.
I
Mohit,
can't
कागज में
really
ink
see.
है ना?
I can't
Even the
really
leg,
Yes,
see
sir.
just above the
any.
medial malleolus, there is a pigmented patch. So you can put it as a C24.
Okay.
Yes,
Let's
sir.
stop.
Just a couple of minutes more. Mohit, just describe the classification for us, please. The whole
Yes, sir.
CAP in the
So,
latest technique.
yes, sir. So CAP consists of C, which is suggests of clinical feature. C1 is reticular veins. C2 is varicose vein. C2R is recurrent varicose vein. C3 is edema. C4 is classified into A, B, and C. C4A is eczema or hyperpigmentation. C4B is lipodermatosclerosis or atrophica blanche, and C4C is coronaphlebectasia. C5 is active venous ulcer, and C6 is recurrent venous ulcer, and C6R is C6 is active venous ulcer and non-healing, and C6R is recurrent active venous ulcer.
Yes.
What is C5?
C5 is healed venous ulcer.
Yeah, fine.
Okay.
And anatomical A stands for anatomical classification. It is suggestive of AN, not classified A as involving the superficial veins. P, which is suggestive of involvement of perforator, and SP means both superficial and perforators. In E, it stands for etiology. It is suggestive.
Hey, what is AN and AP? AD and AP. Perforators, no?
Yes, sir.
Yes, sir.
Okay.
Etiology, it is suggestive of it is primary EP or secondary ES. And in pathophysiology, PR stands for reflux and PO stands for obstruction.
And RO, both reflux
Yeah.
and obstruction.
Both reflex and obstruction. Yes.
Mohit, one last question. Would you offer surgery
Yes,
to
sir.
all the patients? If somebody wants to avoid surgery, what will be your guidance or advice to them?
Conservative line.
I will like to educate the patient and tell him to wear the compression elastic compression elastic bandage or stockings throughout the day and keep the lower limb elevated during night time.
Does
I think-
everyone need elevation or those with edema need elevation?
Yeah.
Ma'am, everyone with dilated veins need
It's
Why?
not needed.
compression.
Patient lies
It
down,
will-
the veins will
it will-
automatically collapse.
During working hours, there will be a reflux in the veins which will get opposed by compression
No,
bandage.
no. I
So to
understand.
prevent
No,
reflex mediated.
okay, stockings are better than compression bandage. Nobody can apply compression bandage appropriately. Okay, so
Yes.
prefer stockings.
Yes.
What pressure?
Ma'am, 30 to 40 mmHg of pressure.
Bapre, 30 to 40. He
Ma'am,
doesn't
in this
have
patient,
ulcer.
I would like to give 20 to 30. Ma'am.
Very
10 to
difficult
20
to tolerate,
in
huh?
this patient.
Very
Plus
difficult to
two.
tolerate such pressure.
Yes.
Will weight loss help in any patient who is obese?
That should be your first line of conservative
Yes, sir.
management. Yes.
Yes.
Weight loss and optimization of risk factors. That is very important.
If patient is having ulcer, which type of bandage is advised?
Ma'am, bandage made up of zinc oxide, calamine, and glycerin mixture. Gauze piece is applied, followed by which 2-layer or 4-layer compression bandages will be given. It will suggestive of it will be comprised of orthopedic wool, cotton crepe, elastic bandage, and cohesive bandage.
If patient starts bleeding from the ulcer, active bleeding from the ulcer, due to
Yes.
erosion of the vein, what will you do?
Ma'am, elevation of the limb and compression.
Okay.
The
Yes, sir.
vein can bleed
Apurva, we
even
can.
without an ulcer. So you must train the patient with superficial veins with thin walls that they should not
Yes.
run to the doctor but lie down with leg up and give compression on that. Because otherwise patients
Yes, ma'am.
start literally running to the doctor and can collapse on the way because they can bleed significantly from the vein, the varix or whatever
Yes.
dilated vein that is bleeding.
Okay, right, sir. Shall we call it a day? I think
Yes,
it
please.
was a very good
Thank you very much.
discussion. Thank you
Thank you
all the
very much, sir.
faculties
Thank you, Apurva. Thank you,
for
madam.
being
Thank
available.
you.
Thank you,
Thank you,
sir.
everybody.
Thank you,
Sir,
Mohit.
thank
It
you,
was
sir.
a
Thanks a
good
lot.
presentation.
Thank you, Mohit.
Thanks a
Yes.
lot.
Thank you.
Thank you, sir.
All the
Yes.
best, Mohit.
Thank you very much, sir.
Thank you, ma'am.
Nice presentation, Mohit.
Very
Thank you,
nice.
sir.
Sir, I have a question.
Thank you. Bye-bye.
Thank you, sir.